Hello, welcome and kumusta? Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversation. And today I am with my regular visitor, Maria. How are you, Maria?
I'm okay.
You're okay? Okay. You haven't had a lot. Of course, you're a regular customer, you're a regular visitor. Welcome to these OT Conversations. This time, I'd like us to have a discussion about this recent encounter, I would say. So there's this case study, right? And I'd like us to have a conversation about this case study, and I'd like to ask you a few things. Is that okay? So here's the case study. Amish,
Mm-hmm.
she is a 12-year-old girl who enjoys swimming and she has recently started learning how to play the clarinet. After a recent growth spurt, Amish found that she was struggling to straighten each of her little fingers fully, making it difficult for her to reach some keys of her clarinet. Amish also complained that she was finding writing a little more difficult during school, particularly towards the end of the day. Amish's mom took her to the GP, who then referred her to a hand consultant, a hand therapist. And then the consultant diagnosed Amish with camptodactyly and asked you to see her for conservative management. And the consultant will review Amish in 6 months.
Mm-hmm.
So did you get the story?
Yeah.
Here's this girl, Amish, 12 years old, quite active, very busy, likes to play the clarinet. But this growth spurt, then it happened. Yeah.
Mm-hmm.
And then all of a sudden, she couldn't straighten the little fingers, getting bent, particularly the little fingers of both hands, which is really strange, isn't it? And was diagnosed with camptodactyly. Tell me, what is this condition? And let's have a conversation about the recent anatomy about these things, about the embryology. What do we know about these things?
It's camptodactyly. So basically, bent fingers.
Okay. And it's just little fingers?
It's a hand deformity. It's a non-traumatic and progressive flexion contracture of the PIP joints.
The PIP. So,
Interphalangeal joints. So
okay.
PIPJ. So it commonly affects the fifth finger.
Really?
Yeah, with possible involvement of the other fingers. But the thumb is always spared.
Really?
Yeah.
That's very interesting.
So
Okay.
it typically progresses during growth spurts.
Okay.
And particularly between 1 to 4 years of age. And
Growth spurs of 1 to 4 years.
Yeah.
So as young as 1 to 4 years old,
Yeah.
you would have this. Okay.
And then the later stages would be 10 to 14 years.
So really growth spurts.
So on those particular time frame where you are growing, so that's when it becomes more apparent.
Or perhaps people just make that referral and they become concerned about it around that time. 1 to 4 year old, yeah, parents would definitely be aware of that. They'd be worried and they'd consult a doctor. And then the other one was 11 or
10 to 14.
10 to 14, teenage years, yes.
Teenage years, when they start worrying about hand function. Just like in this case, she starts to find reaching keys in the clarinet difficult or handwriting difficult.
So with the little finger,
With the little finger. And they start noticing that the finger is not fully straightening, which is not normal usually.
Don't you have a finger like that?
Mine, yeah, I have.
Don't you have camptodactyly?
Mine is a combination of clinodactyly and camptodactyly.
Clinodactyly.
Yeah, it's another finger normally.
And that's not Boutonniere's deformity.
No, that little finger, this one. I'm showing
the right finger.
The
right little finger
is bent sideways.
Sideways.
And also
bent. So what's the sideways bent called?
Clinodactyly.
Clinodactyly. Yeah,
I don't know how you
clinodactyly.
pronounce it, but
And camptodactyly.
camptodactyly.
I'm sure that the dactyl is definitely fingers.
Yeah, and camptos means bent.
Is that what it is?
Yes.
Camptodactyly, ladies and gentlemen, for those of you who are listening, campto is Latin for bent, and clino is the Latin
No,
for
dactyly is a Latin for finger.
yes,
So
finger, but
campus.
clinodactyly would be sideways.
Bent the other, yeah.
Bend the
The
other
sideways,
sideways bending.
yeah.
Oh, that's very funny, isn't it? And it sounds very interesting and very scary because you come to dactyly, ooh,
What
it
is
makes
that?
people go, ooh. So is there any other anatomical thing that needs that be significant, or there's something fun to know about with these things?
In the braille, do we want to go in depth with this? So explaining the anomalies such as can arise from a developmental issue during embryogenesis.
Embryogenesis.
Yeah.
So really embryogenesis.
Mm.
So
So in the
even
early weeks of development,
it's already there.
approximately weeks 4 to 8, the upper limbs form. So weeks 4 to 8, that's when the upper limbs form. Yeah.
4 to 8. Hold on.
4 to 8 weeks.
While the
Weeks.
baby is in the womb.
Mm-hmm.
How did they find out?
Well, you know that in embryogenesis, there's a study about it. They've studied it. So this is just to tell the normal development. Yeah.
Mm-hmm.
So in the early weeks of development, that's when the upper limbs form, the 4 to 8 weeks,
Mm-hmm.
and specialized cells differentiate into bones, muscles, tendons, and ligaments around that age.
Yeah. I definitely remember
You
that.
know that. That's basic.
All right. It's been a while, but yes, occupational therapists. Oh, I remember looking into that when I was in my university days, but that is definitely has not registered a lot. But yes, I remembered encountering it, but because it's something that I've not been practicing. But yeah, wow. Unless I become a embryology specialist OT, then I probably would remember that. So it's
So if
around
anything around that time, something developmentally happens,
uh-huh.
it camptodactyly can start happening around that age. But
Mm-hmm.
so for normal finger extension, there has to be a balance between the flexor and extensor tendons.
Yes.
Yeah, so
that's even for a normal hands
Mhm.
anyway.
And they should be correctly placed and moving across the joints,
Yeah.
especially at the PIP joints. Yeah.
Okay. Okay.
So initially, there's a person called Parks Weber initially proposed 2 forms of camptodactyly. There are so many
Forms.
classifications of camptodactyly.
Okay.
So proposed forms and classifications. I
Mhm.
could name a few.
Mm-hmm.
So there's this Parks and Weber said there's 2 types, congenital types, were described as being present from early life
Uh-huh.
and affects males and females equally.
All right.
With adolescent or acquired types gradually appearing in early teens and more commonly seen in female patients. So it just from the very beginning when I said between 1 to 4 years and 10 to 14, so it just justifies those stages of growth spurt, isn't it?
Uh-huh.
So it's the congenital and adolescent types, and then this another person Glissenstein described camptodactyly as a disorder of the flexor extensor equilibrium in the PIP joints.
Yeah.
So
the flexors are shorter.
yeah. So the flexor is pulling more than and the extensor is being stretched more. So that's why there's a pull to bend. There is no
But can you extend it? No.
it's bent. You can. Those for non-rigid, those who are not set and the joints are still okay. In the early stages, that's
Then
why it's conservative management is important at
splinting.
the beginning. Yeah, because you can still influence that. You can still extend in splints, gradually stretching.
But if it
It's
shortens and
harder
shortens.
when it's already progressed and it's in later stages when the joints are already compromised.
Mm-hmm. Mm-hmm.
It will be harder that way.
Okay. So what do we know so far? Camptodactyly, campto, bent, dactyl is fingers. And then we know that it happens from growth spurts around 1 year to 4 years old, and then 10 years old to 14.
Mm-hmm.
Okay. So almost, it's good to remember that 1 to 4, 10 to 14. Yeah.
Yeah.
And then it is happening. They are theorizing, which they probably remember. The development that has happened in the embryology is around which weeks? 4.
In the early weeks of 8 to 4.
Wow.
4 to 8, sorry. 4 to 8 weeks.
4 to 8 weeks. So the magic numbers are the 4 is
4
the
to
magic
8.
number
Yeah.
in here, isn't it? Nice. I guess for you to remember camptodactyly is if you bend your fingers, it looks like number 4, isn't it? The corner of the number 4. Yeah. All right.
Yeah.
Okay.
So going back to Amish's case,
Yeah.
it could be the rapid growth of her bones during adolescence
Mhm.
likely disrupted the balance of the flexor-extensor equilibrium,
Uh-huh.
causing increased flexor pull in the PIP joints of her
Mhm.
little fingers.
Yeah.
So this could affect the handwriting, isn't it? And the clarinet playing, because if you're bent and you're writing, so you're holding your pen in between your 3 fingers,
Tripod.
and then you have a bent finger that is under the hand, which is being pushed down as well. So the pressure of the writing can affect
Really?
the bending as well. So it could affect handwriting tolerance, won't it?
Would it?
Yeah, there's a lot to complain about that.
Unless you lift your little finger up while
As
you're
you're
writing and you can't straighten it, which is who signs like that? Who writes
Mhm.
like that? But normally
Or
you'd
if
grip it. If you're going to write, right?
Mm.
So if you remember this, you flex you need to have the palmar stability. And you do that by flexing the little finger and the ring finger. It's almost like holding a tissue paper. But if it's bent already, then that's not a problem, isn't it?
But it's the pressure of writing. So when you write, they tend to tuck more.
Uh-huh.
So if you tuck it even more, and then you're putting pressure on the ulnar side of your hand, it can be painful.
I see.
It's not straight away, but the longer you write, the more pressure you put on it, and that's when it starts.
So it's not the pulling that's causing the pain. Is there going to be pain in there?
Not the pulling, not the equilibrium itself, but it's probably the writing, the pressure in writing in that position. Because how do you write? You bend. No,
you write in that way.
yeah. Anyway,
We're just comparing it to Maria's hand because it looks like Maria has campto and clinodactyly combined. That's why she writes the way she does. Okay.
Yeah, but Ameshi, she didn't have this when growing, when she was little. It started as an adolescence. It's a late onset symptoms, which could suggest that there's genetic predisposition. So it says that camptodactyly is hereditary.
Yeah.
So it may present on the later stages, may not be there when she was just little.
Is that why those doctors and pediatricians do a thorough look at the kid? It's like head to toe, shoulders, hand, toes, just looking that everything is okay.
Any anomalies,
Any
congenital
anomalies?
deformities,
Really?
fingers, hands, toes.
That must be so difficult to do because if you're looking at a child and an infant, they're very small and you're just checking, is there anything in there? So that's a different examination altogether, isn't it? But I think on other cultures, it's pretty much the same. It's the old wise women in the village that would have a look at some of the deformities of the child and they would say, oh, this child has an extra finger and therefore this is good luck or a bad luck, or the simian crease, for example. I see.
Down syndrome.
These are all like tales of like uniqueness to the individuals.
Yeah.
Like Ivan the Boneless. Have you heard of Ivan the Boneless?
No, Ivan the Boneless?
Is one of the most cruel Vikings.
And
he doesn't have. He's got the legs were impaired and he's got a wheelchair of some sort, but he's like very cruel. He crawls all the time. Normally he would have been just thrown by the Vikings, but then they made him grow. And then so he's one of the very popular ones. You can watch that in Amazon, the Vikings. So there's a movie, there is a series about that, Ivan the Boneless. Anyways, I digress. Let's carry on. There you go. That's one of those fun. This is always fun when I'm talking with a colleague of mine. What else do we know about that? So there's classifications of camptodactyly, and there are 3 types really. The infantile, and it's common. That's what I remembered. In its common form, it happens during infancy. And yes, you're right, it affects the little fingers. And usually it's just a cosmetic problem rather than functional one, because if it happens and you grew up with it, the child just really adapt. The type 2 would be the adolescent, and it happens females, like you said, 7 to 11 years of age. Yeah, I remember that. And it's again, it does worsen. And then the type 3 would have been the
Syndromic.
syndromic syndrome. Yeah, camptodactyly, and it's present from birth and typically affects multiple fingers bilaterally, and it comes with severe fixed contractures that causes discomfort. Based on the presentation, then Tamish or Amish's, it fits the type 2, which is the adolescent type. Okay, that's cool. But what is the significance? It's just good to know, isn't it?
Yeah, it's just good to know. When you see children with this, you can, knowing the types, you can look into your treatment planning based on that, because you won't look into other syndromes if it's a type 2. You're just looking to function, and you will know the severity based on your assessment. But it's good to know the classification.
Okay. All right. Lichtenstein's framework. Based on Lichtenstein's framework, so there is a
What did he say?
it would be classified as primary or a simple camptodactyly, because it only involves one finger, so there's no syndromic associations. If it's more complicated, then that would have been what, secondary, because the primary is just simple, isn't it?
Simple. The secondary is more complex.
All right.
And really affecting function. So there are a few other classifications, but if we stick to Benson's classification, I think that's the one you said about
Type 2.
Type 1, 2, and 3. So 1 being the simplest, 3 being the syndromic, 2 is complex but a later onset. So I think we'll just put...
No, I think it's based on the age where it happened. Type 1 would have been on their infancy, isn't it? But it's only usually just cosmetic is the problem. Type 2 is more functional, and then type 3 would have been more
that is associated with other syndromes and complex.
Okay. So now, if we have to assess this, how are we going to assess this as an occupational therapist?
To thoroughly assess Amish.
So what would be
we need to have a detailed evaluation and history taking. So it comes down to understanding when the symptoms happen, the onset.
Find out the symptom. Okay. The onset,
so it's good that she's already diagnosed. So that's even easier. You already have a diagnosis. But it's just knowing when it started, anybody in the family who has it as well, things like that. It's about thorough history taking. And then another important factor is, how does it impact on her daily activities?
I think that's what's more important for an occupational therapist, because history taking should have been taken by the doctor already.
And you can read it on the file. But it's a good conversation starter.
Good.
And looking at history and everything. And sometimes some information are missed, so you can add that to your assessment. But what's important for us as occupational therapists is the impact on her daily activities.
There you go. You don't have daily activities impact scale? I don't think there is. Maybe we'll have to look that up, guys. Okay.
Outcome measure.
Homework. Okay.
Any recent changes, such as her growth spurt?
Yes.
Did she suddenly had a puberty or started growing taller? Any changes, any growth spurt? We said about history of camptodactyly, family history, if there's anyone in the family who has it too.
Check for family history. Any recent stages of life, which is adolescent, is there a growth spurt? Okay.
And then you can go into physical examination, focusing on the passive and active range of motion. in her proximal interphalangeal joints to check all the fingers. Is it just the ring finger or
little finger?
Sorry, it's just the little finger, or does it include the ring finger?
Is there one joint? Is there
Yeah.
2 joints? Is there 4?
So,
but what happens if there's the situation and then there is something with the thumb as well?
that's not camptodactyly then.
Oh, interesting, isn't
because it? Because camptodactyly always spares the thumb.
It always.
It
So
doesn't
for
include the
those
thumb.
of you who just happen to come across any growing child, either 1 to 4 or on the teenage years, if there is a bent finger, camptodactyly, but watch the thumb. Because if the thumb
That's
is
what it
bent,
says. Yeah.
then this
There's
would
something
be
else.
something else.
Or maybe a syndrome. I don't
But it's
know.
not for us to
Yeah, it's up to the doctors
diagnose.
to diagnose it.
It's up for us to find out what the functions are.
And she has been referred to us for conservative management. So we're just in the assessment stages. So physical examination, range of motion, to quantify her limitations in flexion, and also so that we can establish baseline measurements to see if, so we can use it as a reference to track any improvements in her joint movements. So that's an important part as well, joint range of movement.
So you have to have a record of it so that when they can come back, you can always compare whether there's improvement or not.
So how do you do that? Goniometry.
Yes, that's the only way on how to measure a joint. That's one of the standardized tool or evaluation tool.
You can guesstimate, but that's not accurate.
Yes. If you're so good, you can really guesstimate.
That's about 30. That's about 40.
That's 30, 40. Divide it into 45, 15 degrees, isn't it? There's 90.
Apparently, there is a study. I just haven't seen this. I should look it up. That comparing guessing and actually measuring.
And there's a high chance.
And there's a high chance it's wrong.
It's wrong.
Yeah.
Oh man.
There's a high chance it's wrong.
I thought there's a high chance that it's right.
No.
So there's a higher chance, obviously, because you're not really measuring. You're just guesstimating, isn't it?
Yeah.
Okay.
Gold standard is measuring. So
Of
measure
course.
with goniometers. Yeah. So that's one. Then another is strength testing. It just evaluate her grip and pinch strength. Pinch, why pinch? Mostly the grip. So you have an insight to the overall hand function. Yeah. And then, and last bit for us is a functional assessment. So what are her concerns? She's concerned about her writing and clarinet playing. So you would want to actually observe that if they can bring her clarinet with her or do some writing with you, just to gauge how her condition affects her activities.
Do you know what you can use when you're measuring that? And you're measuring performance, because there is a functional implication or something that you're measuring functionally. Canadian occupational performance
COPM.
measure, because you can ask them playing the clarinet. That's important to her. Scale it, rate it 1 to 10 in terms of importance.
Are you? How important is this?
Yeah. What's your performance now based on 1 to 10? Especially if you're going to restore the hand, isn't it? Measure the performance, measure the safety, which would not be an issue, and measure how satisfied they are with their ability. Then you do your intervention, whatever magic you can do, and then get her to
ask again,
and then you can see whether that improves.
I find COPM really useful, especially for this age group.
Yeah, because especially if they can tell. Okay, so that.
And then, so that's a functional assessment. And the last bit would be assessing pain and fatigue, because it will help determine whether she experiences discomfort. Especially, it's mentioned at the beginning, she finds her fingers hurt at the end of the day. So is it because as a result of a compensatory mechanism, which is compensating, and that could be painful or fatiguing, is that a term?
Getting tired, yeah.
Getting tired towards the end. So each of these components of the assessment will help in understanding the severity of her condition, so identifying its functional impacts and selecting therapeutic interventions to address specific needs.
Okay. Very nice. Thank you for that. That's very interesting in terms of your assessment. Now, after the assessment, the next thing that we need to find out would be the treatment plan for Amish. So based on the outcome of your assessment, for example, so let's find out what can we do if we want to treat this. Okay.
Historically, conservative treatment has been the first choice for managing camptodactyly.
Uh-huh.
Non-surgical treatment would involve passive or dynamic splinting.
And there are
combined-
evidences to that?
Yeah,
Of
combined
course.
with hand therapies. That's always been the first line of
Uh-huh.
action.
Always.
Always.
It's just been around for
Yeah,
so
they won't-
many years.
Operate straight away.
Yeah.
It's something that, it's bent. Try splinting
Mm.
or try passive exercises.
You know what my rant is about these things
Wow.
at the moment? Especially the growing clinicians or anybody who doesn't know, they'd always be masking or putting the cloak of, is there evidence based to that? Like splinting
Mhm.
and stretching. We've always stretched like bent joints, and chances are the
Dilation.
progression or the worsening.
And mind you, with this, there is evidence that it's useful. It
Yeah.
helps, it delays. But there is also the progression at some stage, like as I said, growth spurt.
Mm-hmm.
So when they hit growth spurt, that's when it worsens.
So that's when you need to have it there so that it balances or it counteracts the extra pull of the flexors.
Yeah.
Isn't it?
Yeah.
Yeah.
And usually, so it's always been said, avoid surgical intervention unless non-operative treatment proves unsuccessful. So that's the gold standard for camptodactyly. That's always been the first line of treatment. And
preventative
intervention.
They would say conservative, but in terms of the interventions of OT, is it restore? Yes, you are restoring the range of motion. That's one. You're not altering anything else. But prevent intervention is through the use of splint. So technically, you are preventing, isn't it?
But again, there's another research I saw recently about early surgery.
Yeah.
Doing surgery before it gets worsened. And finally, that is also effective because, as I said, historically, it's always conservative splinting, first line of action. It just takes
time, doesn't it?
It just takes time. But then, if once it reaches the 60 degrees, so there's always that limit. That's why it's important to measure every time you assess camptodactyly. What they are recommending is surgery usually is reserved for cases where there is persistent flexion contracture of 60 degrees at the PIPJ or a progression of 30 degrees within a year.
Ooh.
So
really,
if it progressed of up to 30 degrees within
a year, but that's you not giving any splints, isn't it?
Yeah.
Because if you give a splint, that
it shouldn't progress.
It should not progress.
Technically, but then you gave a splint comes down to compliance as well. And the splinting regime, how we'll talk about it later about the splinting regime, because again, there is not a set protocol. I couldn't find. I tried to look for a set protocol.
You're an occupational therapist. You prescribe your own.
There's not a set protocol for splinting camptodactyly.
Yeah.
But there are suggestions for some research some suggestions from some researchers about splinting protocol, which we'll get to later on. But it just says that if it fails and it's progressed more than 30 degrees in a year, or it goes to 60 degrees, then you have to refer back to consultant for review and potential recommendation for surgery.
So you would do that if
I
think then you need to have your own cheat sheet for this. Say you are a therapist and you come across this, then maybe you just have to educate the family as well, isn't it? Because keep an eye on this. Make sure that it doesn't go bending, because if it bends beyond, like for 30 degrees in 1 year, or it's a flexed contracture for 60 degrees, then you need to consider a surgical referral. But then the thing is, it's not a protocol. There is no rule about this that states that this should take place as compared to others.
There's a lot of things that you need to consider, whether the child wants it, the family wants it, what pros and cons about scarring. because scarring can also stop function.
Yeah.
And there are some studies as well that despite the surgery, you say you get the finger straightened, and then you lose
they
the
can't
flexion.
bend it.
Yeah.
What's
And
the point?
Yeah. And that's what is more functionally useful, flexion or extension.
Mm.
So there are those things that you have to consider as well. And some children children are prone to keloid or
Formation, yeah.
keloid formation or an aggressive scarring.
Yeah.
Then that again is even worse than having a bent finger.
Oh dear.
So there are things that you need to assess,
So much, yeah.
consider before surgery. That's why conservative again is much better than starting with conservative managed prevention before considering surgery. So we digress. What were we talking about?
We're talking about some of the treatments. So any treatment planning, what would be your goals in here? So how do we deal with this?
Said he's conservative. So splinting, one of the authors, Benson, said splinting alongside structured occupational therapy program, alongside a structured occupational therapy program, as particularly effective for all types of camptodactyly, types 1 to 3. So it also emphasizes the passive stretching can significantly improve flexion deformity and camptodactyly.
Yeah.
So she mentioned earlier about patient education, teaching them the importance of this and the structure. Actually, that is as evidenced as well. Patient education as important as
if they know.
Yeah, it helps promote compliance with splinting and stretching regimens because it says informed patients are more likely to adhere to their treatment plans, reducing the risk of symptom progression.
Yeah.
So based on all this evidence, so we have what? Splinting, passive stretching, and patient education. So our treatment plan will include basically all those things. And what's our goal? She wants to be able to play the clarinet. So long term is to maintain that ability to play the clarinet and write comfortably, supporting her progress in both musical and academic pursuits. So that's long term. So that's maintaining that. And short term would be to improve her. At this point, it's bending. So it depends on what's the measurement at this stage. So we want to improve her ability to reach the lowest key on her clarinet and enhance her writing tolerance. It's not that she can't write, but it's the tolerance is affected because of the compensatory mechanism by increasing the PIP joint extension in her little fingers. So I'd say 10 to 15 degrees initially in that 6 months period.
Yeah. It's a short term, it's measurable, isn't it?
Exactly.
If you want to do 5 degrees, that's fine. If you want to do 10 degrees, that's fine.
Yeah.
And then you'll see how it goes and then come back again. That's putting it in a sequence of ranges. As long as you've got something, and that's what you're aiming for. You don't know, you might achieve that in the first week. If you just keep on stretching, you might keep the hands supple already.
And he has a review with the consultant in 6 months. So within 3 to 6 months of therapy, this is what we want to achieve through a combination of
carry on
the splinting, stretching, a regular practice, and I thought maybe essential adjustments or modifications to support function. Yeah, so what did I say? So patient education, splinting, stretching program, and activity modification and handwriting advice.
Those will be your interventions.
They'll be my interventions.
And goals. That's very nice.
We can go through it in more detail if you like.
That's very occupational therapy, isn't it? Because all the goals are functional. Because if I were a physiotherapist, I would just go, maintain the PIP joint 10 to 15 degrees in 6 months. That's good. I don't care about whether you use it or not, as long as you maintain the joint range.
That's why now as hand therapists, you can either be an OD or a physio. You incorporate all that in that profession. So there's a functional side and there's the restorative MSK side. You put that all together in one profession. So physios and OT can be a hand therapist.
So it is a proper therapist now.
Hand therapist.
You can either be. You're not a physio, you're not an OT, you're a hand therapist.
Yeah.
Wow. When it just used to be occupational therapists can just do this. But I think it's in this country.
I don't know in the States. It's probably, I don't know. But in here.
It's a specialization that you can, but you're still an occupational therapist.
You are an occupational therapist by profession, but as a specialization, you can be a hand therapist.
Just like I'm a neurotherapist.
Yeah, and physios can be that, but you incorporate the same techniques. So you follow the same
protocol
assessment
techniques.
protocols, targets, techniques. Yeah. So you standardize in that way. You don't forget completely about being an OT or being a physio, but you try and put the two together in that one profession. So you see the child as a whole. You become both
Okay.
physio OT.
Thank you. In terms of the treatment that you have suggested, what I'm going to do now is I'll correlate this to the treatment interventions, whether it's restore, alter, prevent, modify, right? So patient education, when you do that, you're doing that that's not a restorative intervention. That's more of a supportive intervention, because you are teaching them and you are creating opportunities for them to learn more on how to manage it. So that is actually you can count that as a supportive or creative intervention. You can actually count that as a preventative intervention too. Splinting. So unless you are progressing it, then that would have been restored. Unless you're progressing the joint range, then that would have been a restorative intervention. But if your purpose for splinting would be to stop the fingers from getting worse in terms of their flexion, then the splinting then becomes a preventative intervention. Did you get my point? Okay. If, as a therapist, your goal would be to increase the joint range or to improve the limitation, then you are restoring. So the splinting becomes a restorative intervention. But if your objective is, and if you've written it in a way where you are preventing the fingers from getting shorter or getting bent more, then it is a preventative intervention.
Can I expand a bit more on that splinting? Because I remember we were talking about a splinting regime or protocol.
Yeah.
Because some researchers suggested a certain protocol for each. And I said, like Benson said, wearing static splints for 15 to 18 hours daily.
Okay.
And then Hori says dynamic splinting for 24 hours a day for the first month, followed by static splinting of 8 hours a day.
Wow.
I just think it's just too much.
Too much. Dynamic splint for a little finger?
I know. And it's, you're not considering function there, don't you? I think for this.
I think I get the point there. The dynamic splint where you have like springs rather than the outrigger. So it's not the dynamic
it's not
splint.
with the outrigger.
Okay.
It's just the springy ones.
Yeah. So that's a dynamic splint.
Yeah, but I don't know. Maybe it's just my
Practical
gut
side.
feeling and practical side of things, that having something like that when doing something, using your hand,
it loses the compliance of patients with.
And also, it just feels like it stretches it back to extension, but you're just working the flexors as well.
Even more.
Yeah, you're type of strengthening your flexors in a way. So for her, my thinking for her, I would think about, based on her age, the routine she does. She plays a lot. She's very active. Her activity level and her writing. She's in school age. She's writing a lot. Writing with splint on is
difficult
and could just affect tolerance even more. So I think static extension splint worn at night and intermittently as often during the day could be more beneficial, as it minimizes interference with her daily activities while improving her range of motion over time. So for me, it's comfort, activity participation, and preference while maintaining compliance will be key considerations in looking into a splinting regime for this
child. So you'd
child.
be more supportive of the night splints.
Yeah.
And I don't mind you supporting that if that is a very good clinical reason. But you said I don't argue with that, because you're factoring in the child, you're factoring in the comfort, you're factoring in when's the best time, compliance, and putting it at nighttime and it's giving it a good stretch. That's quite good. And sleeping is when the body heals itself anyway.
And you relaxes everything, and it just maximizes, gives you the prolonged stretch that you need.
Yeah.
Without affecting
Mm-hmm.
the natural
Mm.
stretch of your hand and muscles and joints. That's just my reasoning behind it. But I'm also torn between whether do we
Whoever
want to
got
be
there
more
first.
aggressive. Do we
Yeah.
want to be more aggressive with it? Do we want to stretch it really long with it? Just like when you wear a cast or when you're serial splinting and you're casting, you put that limb in a cast, you don't take it off and you wear it for 6 months. Those things. Do you want to be aggressive on this or you
Yeah.
just want it to be putting it in a way that they
It's
can
very
tolerate?
tricky, isn't it?
Mm.
It
Where do
really
you?
is.
So I think that's where the argument comes in, and that's where your professional judgment, clinical reasoning for each therapist you can argue.
Mm.
You know,
I think what happens is there has to be a consensus. You can actually apply for a study for this, for a
was more effective.
camptodactyly. Yeah. So you can have camptodactyly. So you recruit hand therapists, try this approach on A. One would be night splints.
But would
Okay.
there be too many variables though with this age group and
If you
lifestyle?
try that, just those two approaches, one is aggressive, one's the other one. And then at the end of the day, you're measuring the hand because the hand is somehow consistent in presenting the problems. The problem is the little finger is getting bent. So you can have a study where you get the cohort, the participant, meaning only the primary camptodactyly, the only the small, the little finger. So that meant that you're suitable to engage in this study. And then you give them a choice, the choice being night splints or aggressive splints of throughout the day.
Yeah,
And
that's
then
a
if you
good
do
comparison.
this, and then after a while you just review, and then you can easily measure this after a while using, you'll have some clinics. And then what you need to do is you need to have a group of people that will do this. And this is going to be a long-term study. This is going to be a study that will take years. Others would be a PhD on this, but you can ask for grants for this. Isn't that interesting? And then you will develop the protocol for this. The thing is, it suitable enough to do this
Yeah,
in terms of
numbers.
in terms of the money and the time? But if it's your job and you're a scientist, we are scientists, it's up for us to find out. You have two different approaches and there's no agreement. Few people have tried the aggressive ones based on the protocol, based on what people have published.
It is a suggestion, but I don't think it's proven. It's
Yeah,
a recommendation for splinting.
yeah, it's their suggestion. But then you can argue if you're a business medical practitioner, if you're a business hand therapist, like in the States, for example, you'd want to develop a program because people will want to go to your program. What you're doing is you're selling the program, isn't it? And people under insurances will pay for these things. There we go. Stretching exercises. What is this? Is this a restorative intervention? I think it is a restorative intervention if you're doing, and you can also argue that it is a preventative one. All right. Okay. So what else?
Activity modification.
Activity modification. Oh, that would have been an adaptive intervention. So that's a modify intervention. Yeah. So for those of you who are listening, and just to give you a clarification of what am I talking about, this restore, alter, modify, prevent. These are the general types of occupational therapy intervention, general classification of OT intervention under the model called ecology of human performance. Just listen to the previous podcasts that I have. So there is that ecology of human performance. I can't remember for the life of me as to what episode number there is, but just scroll along, look at the previous episodes, and it is a very good one. And particularly with the restorative interventions, it's suggesting as long as it's a something that restores whatever technique you use, it's stretching, splinting, you can do NDT, you can do biomechanical approaches, and it's really restorative intervention. Okay, so there we go. Now, I guess we're on to the final discussion. What would be the potential roles, do you think, of interdisciplinary team in here when it comes to Amish's treatment? Do you think, are there any other treatment that could be appropriate for her now or maybe in the future?
Mm. So with her case, so she started to see a doctor. So I would assume. So by the way, Amish is a hypothetical name, so it's not
Of course,
yeah.
this
This
by the
is
way, for this is not a real,
this is not
this real
real.
name. This is all a it's fun and
Mm.
games. So
So we're just learning to a case.
mhm.
So with her condition, she potentially the parents or she started noticing the bending of the fingers. So just and it's affecting function. So they started seeing a GP. So in the UK, so GP is their first point of call for the NHS, point of contact for NHS patients.
Mhm.
So they assess the condition and make referrals to appropriate specialists.
Mhm.
So Amesh, she was diagnosed by a hand consultant, but via referral from the GP, and then referred on to our service for conservative management. So that's
So 3.
3.
So
So GP,
GP, Jinx.
hand consultant,
Uh-huh.
and then occupational therapy hand therapist. So assuming so that's me. So I'm an occupational therapist, but also a specialized pediatric hand therapist. So
So they can go directly and bypass an occupational therapist.
a hand
You can
therapist.
go direct to a hand therapist,
Yeah.
pediatric hand therapist to be precise. Although adult hand therapists can do it
Yeah,
as well.
adult hand therapists can do that,
Yeah.
and that's hand therapy.
They just don't normally deal with pediatric cases.
So this is a specialized route toward to pediatric hand therapy. If a service has that, then that's good. So that can just go directly, can revert directly to that service. So the role will involve assessing the needs and creating a client-centered treatment plan based on current evidence. So be responsible for liaising with the consultant to report on her progress.
Who's gonna do that?
Therapist. So that'll be
Yeah, it's everybody's duty, isn't it?
Yeah.
Particularly in a scenario where it's a there is a referral process and people don't share offices. Because like the GP is from geographically from one place, will send a letter to a consultant, hand consultant, who's maybe holding a clinic in one specialist hospital, who would assess and then would be referred on to an occupational therapist. So all the referral processes back in the days would have been letters, isn't it? But now it's all computer and emails. So you have that. So that is where I think the process of occupational therapist of assessment, review, reason for assessment, that's really very important. You know, as compared to when you're working in a hospital where you can just grab everybody in there. So here you really have to follow the process.
Yeah, and keep that liaison with the referrer, especially
Of course,
in this case.
you have to report.
Yeah, you have
Whatever
to
you've done, you have to report back to the one who asked you. Because when you know other means of referral, the referral by definition is the referrer is consulting you, is asking for your opinion and help on a particular matter. And when they do, it meant that you need to respond back to them. Yeah.
Yeah. So once you've done your conservative management, which we've already talked about, all these conservative treatments, so we monitor the progress. And of course, also when we talk about work activity modification, you can also think about school. Is there anything that you can do to support her in school, like reasonable adjustments, possible extra time to written exams if it's really affecting handwriting tolerance?
Yeah. Does that mean you'll have to write a letter?
Yeah.
To
a
whom should
report.
you send that? To a teacher?
It could be the teacher, or if they
Head
have their
teacher?
special educational needs coordinator, or it could just be, I'd usually link in with the special educational needs.
But there is a big but there.
Why?
It looks like Amish is just a regular child.
Yeah.
So in a regular school,
But if she needs reasonable adjustments and we are recommending it
who
for
would
her
you
performance,
refer?
it could be, we have to ask.
Who?
Each
Okay.
school would have, because usually the Senko would do it. They would be in contact with the teachers.
What's a Senko?
Special educational needs. Although it's not
Special
as it's
educational
not
needs.
yeah, the coordinator. They're coordinators.
Senko.
Yeah.
Nice.
Yeah.
Yeah.
It's a coordinator.
So special
They're
educational needs coordinator.
But you're right, it could be not that complicated for them because special educational needs would be like children
in a special
in
school.
No, each school would have
Each school would have one in the United Kingdom. So this is good for us to know, guys.
Should. And
It
I've
should.
always linked in with special educational needs coordinators in each school for my children. But I'm not sure the limitation. Will it be more the complex cases only? Because sometimes you can link in directly to the teachers as well.
Gosh, imagine it. So how old would Amish is now? It's about growth spurt.
12.
Yeah. Yes, 12 years old. Are we expecting any exams? GCSEs?
Not yet.
Okay.
Thank goodness, not yet. It's about 16 that GCSE.
Okay. But what the other ones?
Around year 10, year 9, 10, and 11.
Okay.
Those are difficult stages because that's when they start preparing for GCSE.
Yeah.
And 5, 6, year 5, 6 works of SATs. So especially, what does SAT stand for? It's an exams for
Scholastic Aptitude Test.
Possible.
I don't know.
I don't know. But SATs for year 6s. And 7 is just the beginning of secondary school. So not too bad. Year 12, at 12 years old to 13. So yeah, so any reasonable adjustments for school, you just explore on those strategies and support. So that's what's good about being an OT coming into hand therapy, because you can those areas
all the time. It's always good to be an occupational
it's
therapist
holistic.
because
you can see everything. You're not just focused on the finger, you're focused on everything else.
I know, it's annoyingly good, isn't it?
Yeah.
Yeah.
So you monitor the progress with activities, and it also includes her ability to play the clarinet, which also a key part of her.
So you'd be linking with a music teacher?
Possibly, if it's really affecting. Yeah, actually, you do, because you can recommend. Because some music teachers won't know about that type of deformity, and they will just think you're not stretching your finger enough, and you'll keep pushing and pushing.
So you have to educate the teacher.
Some will have to let the teachers know. I have one that's a violinist. That's an issue.
Yeah.
That's an issue. And the teacher don't understand why the finger's sticking out. It's the opposite of camptodactyly.
What would that be? I can't remember.
It's another story.
Homework, guys. Homework.
It's another story. But it's education. It's part of education. And then we're talking about future treatments she might tap into, which is, as I said, surgery. That is the last resort of treatment. If everything else fails, conservative treatment. And just to repeat again, if there's a 30 degrees progression within the year, and then there's persistent flexion contracture and comes to 60 degrees, then that's already alarm bells for you.
Okay.
Go back to the doctors, explore options of surgery.
And this is different from Dupuytren's.
Yeah, no, Dupuytren's it's very different. It's another topic, but Dupuytren's is not the same as camptodactyly.
Because you can see it in the palm.
It's shortening. It's not.
It's a contracture.
It's a contracture, yes. And you can see it in the palm, and it's a different. We'll talk about it in a different
topic
season,
different topic.
Podcast.
Okay.
Yeah.
Okay. I think that is so most of the things that I wanted to learn about this camptodactyly in this particular case scenario. So yes, you'll talk about occupational therapists, you'll talk to a hand therapist, physiotherapists, yes, they can do that too. Would there be a referral to a physiotherapist?
If it's affecting other strength,
musculoskeletal, these are joint range, so it's a physical problem. And
if I'm not a hand therapist, I would refer a physio or a hand therapist. If it's affecting function and strength, that's why you're assessing. You can assess grip strength, and you can go back to them and say, "Can we get exercises?
Just give them a pair of ball or
exercises."
Yeah,
you can do that, but then you can include that in your treatment too.
Yeah,
it's a lot more functional.
Yeah. Okay. Wow. I guess that is quite a thorough conversation that we've had about camptodactyly, guys. It's a very interesting topic. Any advice for people who is listening Just watch those growth spurts.
Mhm.
Keep an eye on those little fingers
Yeah.
and other fingers. If they begin to bend, and for some strange reason that they are, the sooner you contact your GP, the better, because there's higher chances that they can refer to a hand specialist straight away. Would
Mhm.
there be a specific doctor? A hand specialist doctor?
In this country, it'll be the plastic surgeons.
Isn't it?
Mhm.
So it's usually a plastic surgeon or
With the hand specialism.
or a surgeon, a hand surgeon.
Mm. I don't know if orthopedic does it too. Maybe some orthopedic, but it's not bones, isn't it?
Uh, so normally from your scenario,
It will be plastic surgery.
it's plastic
Plastic
surgeons.
and reconstructive surgery.
Really?
That's the specialist team I
Wow.
work with. Yeah.
So what are we talking about? The hand specialist doctor? There's none. Oh, but because it's just a
It's
scenario.
hypothetical.
Of course, it is hypothetical. Jeez, I got lost in this hypothetical case. Guys, that is a wonderful conversation, a wonderful topic. We've learned a lot. I have learned a lot. I certainly enjoyed it. I certainly enjoyed chatting and catching up with Maria once again. Just remember, guys, if you enjoyed this, have a conversation amongst each other. Talk to your friends about it. Talk to your colleagues over a cup of tea. Learn together and grow together. Just remember, anything you do matters and has an outcome. Until next time,
Bye.
bye.